Module 1, Assessments. Questions in this section will comprise 46% of your COMT exam. Our first section is History and Documentation. Questions from this section will comprise approximately 3% of your exam. History taking is one of the most important skills that you must possess, and it's something that you'll get better and better at throughout your whole career. The chief complaint is the main reason that the patient is there. This might be follow-up of a previously diagnosed condition, or it might be a new problem that the patient's having. Start with the last impression, last plan, and last chief complaint, and go from there. The history of present illness is detailed regarding the chief complaint, using the descriptives that are listed here. The review of systems is a list of questions arranged by organ system, designed to uncover dysfunction and disease. It's important to understand that this question and answer of review of systems is just one piece of the clinical puzzle. The patient's responses must be interpreted within the context of the rest of their findings, including their risk factors, their past history, and their exam findings. For example, if your patient complains of shortness of breath, we would then further define this with its symptoms, including duration, precipitating events, severity, character, associated symptoms, etc. On the basis of this data, the physician can come up with an informed conclusion about the importance of this review of systems symptom and use it as a guide in their medical decision making. The purpose of the ocular history is to uncover what types of eye surgeries they've had, any major diseases or infections, if they've ever had any eye trauma, and also what kind of prescriptive lenses they wear or have ever worn. The purpose of eliciting the social history is to determine what sorts of lifestyle habits the patient may have, which may impact their health. The family history is important because many diseases have a genetic component. When taking a history on a pediatric patient, you want to ask about how the pregnancy and the birth was. Did they have a routine birth, or was it assisted with a vacuum or forceps? Have they met their developmental milestones? Also find out about their medical, family, and social history. When asking patients about allergies, don't just think of drugs. Also think of contactants, ingestants, inhalants, foods, seasonal allergies, environmental allergies, and dyes. Let's examine what happens during the allergic response. You have an initial exposure to an allergen. You may have a mild reaction, or you may have no reaction at all. Then the body makes antibodies. This period between the initial exposure to the allergen and the time that you have the allergic response is known as the induction period. The induction period can last minutes, hours, days, weeks, months, years, or decades. Then you have a subsequent exposure. It might be the second time you're exposed to it, or could be the 100th time. At this point, the body releases mast cells, which are filled with antibodies. The mast cells release their enzymes, which are histamine, and this is what causes the allergic response. When you're taking a history, be aware that there are different types of vision loss. Let's talk about some of the different types. If the patient has a loss of central vision, they may complain that their vision is better in dim illumination than it is with the lights on. If it's a sudden onset, it's usually due to optic nerve or macular disease. Distorted vision can occur due to macular disorders, high myopes, or thick glasses. Frequently, if it's due to high myopes or thick glasses, the patient may state that objects appear minimized and fuzzy with curved edges. Let's talk about some other types of vision loss. Night blindness can be a symptom of retinitis pigmentosa or a deficiency of vitamin A. Transient vision loss can last seconds or minutes or hours, so find out how long it lasts when it occurs. And it's also very important to ask, is it one eye or both? Transient vision loss can be a sign of swelling of the optic nerve or papilledema due to an increase in the intracranial pressure. It can also occur secondary to coronary artery disease or carotid insufficiency. If a patient states that they can't see to their left or to their right, they may also complain of difficulty seeing to do their daily tasks or trouble getting around. If they have a visual field defect where they can't see on the left or the right, we would suspect neurologic origin on the opposite side of the brain of the visual field loss. Patients who have superior retinal detachments will frequently state that they see an ascending veil or a dark shadow arising inferiorly in their visual field. When patients complain of blurry vision, always ask, is it at a particular distance or with a specific activity? This is because blurred vision due to uncorrected refractive error will typically occur at a particular distance with a specific activity. Blurry vision due to organic disease will usually occur at all distances with all activities. Our next section is ocular motility testing. This section will comprise approximately 7% of your COMT exam questions. There are two basic types of eye movements. The first are saccades. Saccades occur when you're looking at stationary objects and you have fast movements from one target to the next. Saccade movements originate in the highest centers of our brain in the frontal lobe. Pursuit eye movements occur when you're looking at a moving object. These are smooth, slow tracking of a moving target. Pursuit eye movements are one of the first neurologic milestones in newborns. The highest centers in the occipital lobe are what innervate this function. 6 extraocular muscles control the movement of each eye, 4 rectus and 2 oblique muscles. Each of our 6 extraocular muscles plays a role in positioning the eye about 3 axes of rotation. The primary action of any given muscle is the principal effect it has on eye rotation. Lesser effects are called secondary or tertiary actions. The precise action of any particular muscle depends on the direction of the eye in space. The medial and lateral rectus muscles adduct and abduct the eye, respectively, with little effect on elevation or torsion. The vertical rectus and oblique muscles have vertical rotation and torsion as their chief functions. In general terms, the vertical rectus muscles are the main elevators and depressors of the eye, and the obliques are mostly involved with torsional positioning. The vertical effect of the superior and inferior recti muscles is greater when the eye is abducted. The vertical effect of the obliques is greater when the eye is adducted. There are 6 cardinal positions of gaze: up and right, right, down and right, up and left, left, down and left. The cranial nerves which pertain to ophthalmology are the 2nd cranial nerve, the 3rd, the 4th, and the 6th. The 2nd cranial nerve is the optic nerve. This is the nerve which sends light messages from the retina to the brain. The third cranial nerve is the oculomotor nerve. This nerve originates in the brain and is carried forward to the eye. The third cranial nerve innervates your medial rectus, your inferior oblique, your superior rectus, and your inferior rectus extraocular muscles. The trochlear nerve is the fourth cranial nerve. This cranial nerve innervates the superior oblique muscle. The abducens nerve is the sixth cranial nerve. This nerve innervates the lateral rectus muscles. The mnemonic to remember your cranial nerve innervation is this: SO4LR63. This means that the superior oblique innervates the fourth cranial nerve, the lateral rectus the sixth, and all the other extraocular muscles are innervated by the third cranial nerve. To perform the alternate cover test with Prism, you must first disassociate the eyes and break binocular fusion. Once this is done by covering one eye, the amount of deviation is measured using prisms to eliminate the eye movement as the cover is alternately switched from eye to eye. It may be necessary to use both horizontal and vertically placed prisms. The amount of prism power required is the measure of deviation. Two horizontal or two vertical prisms should not be superimposed on one another because this can induce significant measurement errors. Their values cannot be directly added either. A more accurate method for measuring large deviations is to place prisms in front of each eye, although these are not perfectly additive either. However, it is acceptable to superimpose a horizontal prism on a vertical prism before the same eye if necessary. The simultaneous prism and cover test is performed by covering the fixating eye at the same time the prism is placed in front of the deviating eye. The test is repeated using increasing prism powers until the deviated eye no longer shifts. Accommodative amplitude and accommodation range is measured in diopters. The accommodative amplitude is the maximum increase in dioptric power which an eye can attain, and a range of accommodation is the linear distance when one can maintain clear vision by using one's accommodation. The von Graefe technique is a dissociative test for phoreas. It measures the horizontal and vertical deviations in the phoropter. The patient looks through the phoropter with the distance or near prescription in place. A target is isolated, usually a single letter, on the Snellen chart, one line above the best visual acuity of the worst seeing eye. 12 prism diopters base in is dialed in with the Risley prism in front of the right eye, and 6 diopters base up prism is dialed into the Risley prism in front of the left eye. See handouts for more detailed information on this test. Purkinje images are reflections on the surface of the cornea and the lens when the eye is illuminated from a light source. Typically, the angle kappa can be determined for a particular eye using Purkinje images. There are usually at least 4 Purkinje images visible. P1 is the outer surface reflection or glint. P4 is the inner surface of the lens. P1 and P4 are used for devices which use gaze tracking technology. When we look at an object of regard, each eye has a retinal point which corresponds to a retinal point in the fellow eye. When they're both stimulated, they produce the same visual image. In anomalous retinal correspondence, the brain develops correspondence between retinal points that would not normally correspond if the patient's eyes were properly aligned.